A very good morning and welcome to this session titled Future-Proofing Health Systems. My name is Nzinga Kunta. I'm a business news anchor on the public broadcaster in South Africa, and it's my great pleasure to be moderating this discussion as we take a look at the impact of COVID-19 on our collective lives and lessons that can be learned from the pandemic. The dramatic spread of COVID-19 disrupted our lives, livelihoods, communities, businesses, and economies worldwide. Today, we're going to be taking a look at how policies, partnership, and practices can ensure that we scale up health systems and adapt them in a way to ensure that there's resilience and uninterrupted care, even in times of crisis and shocks like the ones we've seen over the last 2 years. On our panel today is Jayashree K. Iyer. She's the CEO of Access to Medicine Foundation. Leif Johansson, who is the chairman of the board of AstraZeneca. Chief Minister Jagan Mohan Reddy from Andhra Pradesh. Catherine Russell, who is the executive director of the United Nations Children's Fund. We will be taking audience questions a little bit later on, but perhaps for now we'll start the discussion. Leif, I'll start with you. As one of the companies at the forefront of the response to COVID-19, what lessons would you say you've learned from the pandemic?
Well, I think you remember that we responded by making 2.9 billion doses of vaccine, delivering to 183 countries, two-thirds of which were low and middle-income countries, and at no profit. So I think that was an immediate response just by saying, answering the question, can you help? And we said, we'll try and do what we could, and that worked out very well. I think the lessons in the immediate crisis really was that we need to think about going to places where we normally don't go. In our case, that meant going to academia and collaborating directly with academia, and then in a way such as to produce billions of doses of vaccine to really scale up. I think in the immediate, again, lessons learned from a government point of view should be that there need to be funding made available, decisions already having been made, like in the US, and which is now being discussed in Europe, to have funds available for the immediate crisis. Longer term, I think there are actually a few more lessons there. We are participant with the PHSSR, which is the Health, Sustainability and Resilience project that WEF and we and London School of Economics are running there. I think there's some very interesting data coming out of that. 97% of all healthcare cost is being spent at hospitals when patients present at the hospital being ill or at the general practitioner being ill. 3% is spent on trying to prevent and detect early disease. I would suggest that probably should be 80-20 or even 60-40. But for different reasons, and we can discuss what those are, that doesn't happen. I think what we can do with the PHSSR is to show pilots and countries that are doing remarkably much better by making sure that people are not getting sick rather than to treat them when they are ill. And I think that's a very solid lesson that we should try to take to heart when we look over the next couple of decades.
Jayashree, we can't speak about a pandemic and medicines without talking about how there was a disparity in access to vaccines in developing versus developed nations.
Yeah, no, absolutely. I think that the COVID-19 pandemic has definitely put a spotlight on a chronic issue in healthcare, inequity of access. You see that with the vaccines. You see the high-income countries, within a year of delivery of vaccines, achieved about 75 to 80% coverage, and in low-income countries it was less than 10%. And I think that represents, a change that needs to happen, where innovators need to think ahead on how they're improving access. I think the actions that companies like AstraZeneca has taken in prioritizing access to low-income countries makes a big difference. In our research, we've also seen that there's about 8 out of the biggest 20 companies that have been today prioritizing access by making sure that every product that's in the research and development pipeline goes through a set of criteria to see, okay, which countries is it going to be made available in? But the reality of it is actually really vast. I mean, in our research, when we analyze all the different products that are being made by the pharmaceutical industry, we see that about half of the products do not have a system in place to bring these products to low-income countries. So the inequity is huge, and we forget that 80% of the world's population live in low and middle-income countries. We forget that inequity is not only there for vaccines and medicines, but also life-saving products such as medical oxygen, which has been a long neglected issue in the healthcare crisis.
Minister Reddy, if we're talking about the crisis that some countries are still in, talk to me about what happened in Andhra Pradesh and the interruptions to healthcare there and how you managed that.
COVID was one particular pandemic that nobody ever anticipated. At least we have not seen that kind of pandemic in our generation. So it was something that was unprecedented. And the entire healthcare system, which was present till then, had to be re-looked into in order to prevent something, in order to be a formidable force. If at all something like this were to reoccur, then I think this actually taught us quite a few lessons, especially on, moving on to the importance of preventive and curative care, and also making sure that the healthcare system is available to everybody, is accessible to everybody, and also making sure that it is affordable to everybody. So all these aspects were an eye-opener to all of us. And within the limits that we had, we did everything what a country could do or a state could do. We were more focusing on tracing, testing, and treating, because we, from my state's perspective, we are short on tertiary care, because tertiary care, we were a newly formed state, and we do not have a tier 1 city like Hyderabad or Bangalore or Chennai, where private investment is huge coming into and super specialty hospitals. So since we had that handicap with us, so we wanted to get into the early stage, detecting at the early stage. So we conducted almost 44 rounds of house-to-house survey. We had a robust system in place with a village secretariat at every village, a volunteer system for every 50 houses. We had 42,000 ASHA workers, also the volunteers dealing with health issues be present. And all these factors put together, we initiated this process of house-to-house survey. And in this close to 2 years of this pandemic, we've conducted almost 44 rounds of house-to-house surveys. So that was one of the primary reasons as to why we could cut the mortality rate. Even though the country's mortality rate was 1.21%, our state's mortality rate was the lowest in the country, 0.63%. So that's one of the primary reasons.
So, Catherine, we're hearing about the challenges that have been experienced due to the COVID-19 pandemic on the healthcare system, but of course it's not alone there. There's also a migration crisis that's testing already stressed healthcare systems, with disruptions reported in essential services and care in over 90% of countries.
I think the way we look at it from UNICEF is that there are cascading crises for children. Certainly the COVID crisis was a huge challenge for children. It drove, we're estimating, another 100 million children into poverty. It kept children out of school for months, if not years, right? It interrupted routine vaccinations. I mean, COVID was devastating for children, but you're right, it's not the only crisis. We also have conflict in Ukraine, which is ending up in millions of people being disrupted there. Certainly children are leaving the country, children are moving around in the country, so displaced in the country. But it's also, I'm sure people have seen this in the press, but it's affecting wheat prices and oil prices, and that also has an impact on children. I was 2 weeks ago in Ethiopia, in the Horn of Africa, to see what's happening to children there because because of the food shortages, and it's devastating to see it. You know, populations are moving because the animals are starving to death. People are severely malnourished, and I visited children in a hospital who were so acutely malnourished that you walk into the room and it's completely quiet because the babies are too weak to cry. So all of these crises are sort of impacting each other, reinforcing each other, and the impact on children is devastating. And I think when you look at, on the healthcare side, having decent primary healthcare in these countries would be incredibly helpful, and that exists in some places, but unfortunately not enough.
Lev, when it comes to the issue of sustainability and pricing, which can also be a barrier to access, what are you thinking of as AstraZeneca, and also when it comes to your carbon footprint?
Well, first of all, I think what we're seeing now are many of us, governments, but also companies, realizing that health and sustainability goes together, and especially so with climate change. And good examples of this is respiratory disease with air pollution, probably produces millions of deaths every year. Contagious disease is certainly one of those, but also everything that has to do with cancer, exposure to different substances, etc. In the case of climate change, we are trying to be doing our part. About 4 to 5% of the world's global footprint is actually coming from the healthcare sector. We are trying to be doing our part in our case by having reduced since 2015 about 60% of our carbon footprint up until now, and we are planning to go zero before 2026 in scope 1 and 2, and then 2030 also in scope 3. All of those are powerful measures, and of course the reason that we are doing that is that we realize that there is a real tie between the two. What is good, I think, is that the world is realizing that also, and I think there is a way to promote now both healthcare systems, sustainable and resilient health and healthcare systems, and climate at the same time. Then over time, when it comes to access to medicines, that's going to have to be done by, over time, building resources in broader continents. The only alternative to that I see is really good trade agreements, but they then need sanctions so that we don't end up in the vaccine nationalism that we had over the past couple of years.
Speaking around that issue, Jay, just talk to me about the Access to Medicine Index. What is it?
So the Access to Medicine Index is a biennial ranking of the pharmaceutical industry's efforts in improving access to healthcare for about 106 low and middle income countries. And basically it's a research system where we evaluate the efforts of different pharmaceutical companies. So this is the biggest pharmaceutical companies in the world, the likes of AstraZeneca, who in the last index sits in the top 10 of that ranking. And what it ends up doing is we come up with best practices, we come up with gaps and opportunities in looking at issues such as future pandemics, issues such as children's health care, whether specific populations in the least developed countries are also being taken into account when you think about market access issues itself. And we bring the research to different settings. So companies use this research as a benchmark of their performance. Investment firms, such as the many different sustainability-linked ESG users, we have about 150 to 200 investment firms that use our work in engaging with the industry, and together they manage about 25 trillion US dollars in assets under management, and they use the money to basically they use the insights to invest differently in the pharmaceutical industry to push for long-term change and a more inclusive and stronger social impact in this work. And of course, governments, many of which have been growing in the usage of our work, use it to shape their policies and the strategic investments into healthcare. By defining where the gaps are and where the opportunities are, we try to make sure that people pay attention to the most critical issues in the environment. And we've basically launching a new strategy now where we're bringing a more diverse group of players and evaluating that effort. So we're looking at big generics, medical oxygen, where there's only 6 manufacturers supplying the whole world's supply of oxygen to people all around the world. Vaccines, diagnostics, and a lot of issues such as local manufacturing, local availability is coming to light. Yeah.
Okay. Minister Reddy, you were speaking earlier on about the challenges that you faced in the context of a newly formed state and trying to respond to the pandemic. Just talk to me then about how do we future-proof health systems against those kind of pandemics that you've spoken about from a governance perspective as well.
As I said earlier, governments would have to be focusing on two things. One is preventive care, and the other is curative care. And looking at this from the lens of how to improve this healthcare, one would have to be talking about availability, accessibility of healthcare, and also affordability of healthcare. All these three would have to be moving in line. In order to do that, from my state's perspective as to how we have been wanting to move forward is, we've taken every 2,000 people, every population with every village with 2,000 population as a unit, and we're coming up with village clinics.
Okay.
And then we're taking up every 30,000 population as a unit and classifying it as Hon'ble, and where we're coming up with 2 PHCs, primary health centers. These primary health centers would have 4 doctors, 2 of the doctors present in each of the PHC center, and they would be given an ambulance, 104, and each of this doctor would be given their designated villages. So 5 villages or 4 villages, depending on the mandal size, to each of these doctors. And these doctors, every alternate day, would hop onto the ambulance and visit the village. And they would become the family doctor for that village. Very soon the doctors, because they've been designated only those 4 villages, so they would start to identify people by names, and they would use this village clinic as a hub. This village clinic primarily would be having an A&M, nursing graduate, mid-level health practitioner, and ASHA workers that we spoke about also reporting there. So that would take care of the preventive part. Now comes the curative part. The curative part would be dealing with the community, with district hospitals, the teaching hospitals. The area hospitals and the teaching hospitals are going to play a very critical role there. So there we're coming up with every parliament taken as a unit in order to ensure that there is equitable distribution of teaching hospitals. Because only when you establish teaching hospitals, you have postgraduate students actually coming up there. And only when you have postgraduate students doing their course there, and these teaching hospitals are connected to a hospital, a teaching hospital as well. So teaching college and teaching hospital together would become the tertiary care that we are looking for.
Okay. We're going to come back to that issue a little bit later on if we've got time. Catherine, when we're speaking about migration, is it correct to quantify it as a crisis, 1? And 2, what possibilities are there for planning scenarios where even if there is a crisis, there's resilience in healthcare services, and there's also a form of adequate care?
Well, yes, it's absolutely a crisis. I mean, the estimates are that 36 million children right now are in migration, sort of crossing borders, and another 20 million are moving inside countries, so IDPs. And that's a horrible problem for children around the world because it's so unstable for them, right? They're moving from one place to another. We don't have good data on whether there is sufficient health care in these migration situations, but we know there's typically not, right? It's very hard. And we encourage countries that are receiving these migrants to incorporate these people into their own health systems, but I can't say that that's happening very much, and so it's very difficult. You could imagine things like routine immunizations, things that matter to children, nutrition, maternal care. All of those things are so disrupted when you're in a situation of migration, as you can imagine. As the minister said, really what you need is good primary health care. That's the single most important thing. And trying to build that up in countries and in situations where migrants are living is really the most important thing. But we're living in a world of very difficult circumstances and very fragile systems that really need to be built up, these healthcare systems, because as we saw with COVID, I mean, even a country like the United States, Western countries are pushed to the brink with something like COVID. So imagine countries that don't have sufficient health care, right, that can't provide that for their people. So we see this as an opportunity now to go in and really try to build up these systems, and that requires good governance, which you're seeing from the minister, but it also requires sustainable resources, which is always the challenging piece.
If we keep using this word resilience when we're taking a look forward at the future, what would you say, how are we going to build resilience so that when the next pandemic comes along, because this won't be our last one, we've taken the lessons that we've learned around that and used them for that?
Well, I think there are obvious places where, for example, we almost had just-in-time as religion when it comes to many countries when it came to protective equipment. That's easy to do something about, but it requires a little funding to get higher inventories of protective equipment. There is lots to be said about preparing for how to actually build medicines, how to do medicines in different countries and different continents, and be able to roll that out at scale quickly. And to do it quickly, it requires preparation to be able to do it. I would argue that good sanctionable trade agreements, such that we don't end up in immediately losing resources on a world scale just because one country does this or that, are the types of measures that we could take, longer term and more difficult, but it would build a greater resilience. We have a war call right now in many countries that says autonomy, and we should be very autonomous. All of that is good up to some level, but it creates an enormous complexity of duplication and cost if we are to do it at each country. So I would start with the first aspect of saying, let's try to make global agreements in such a way that they will actually hold even in a period of crisis. All of this, very interesting.
In a minute, Jay, how do we plan to mitigate risks like supply challenges, wars, and access in the future?
In a minute.
Yes.
So I think that early awareness and early thinking is absolutely critical. In the case of the industry, early planning for access, so that when you're designing a product, when you're thinking which products should be part of the research and development pipeline, already needs supply, needs to be taking account of supply issues, affordability issues, and how will a particular product be used in a primary or tertiary care system. I think at the end of it, you definitely need to see a closer collaboration between industry, public partners, and nonprofit organizations, getting the patient voice early on board in order to make sure that the right products are being developed, the right access plannings are being there. And I think the last thing is, the efforts of an innovator, if done wrongly or if done rightly, may have a huge impact on the downstream inequity issues. So you end up putting more pressure on a health system that is already stressed if you don't think about how to relieve that stress up and early.
Thank you so much. Yeah. I'm going to open up the floor for questions now, and I'd like to begin with Kezavino Aram. Please let us know also if you would like to ask a question. You can raise your hand and let us know if there's a specific speaker that you would like to direct the question to.
Thank you very much. It's very encouraging to hear all of you. I think two things, and then I'll come to the question. First is I think the pandemic has shown us fundamentally if health is not prioritized, everything can come to a stand down. So Chief Minister Reddy, it's so encouraging to hear you. To you, my question would be that strengthening of the primary healthcare system requires a lot of effort. We know of the doctor population ratio. We know that we don't have enough doctors, but the pandemic has also shown us imagining new partnership, the religious communities and their assets, for example. So that's the question to you. And the second question, of course, is to companies like AstraZeneca, which have made such a huge difference in the transfer of not only intellectual rights and products and vaccines. India is a beneficiary. India is also a contributor. Is how do we keep children as priority? I'm not asking our colleagues from UNICEF, but I'm asking you. I come from a country where 44% of the population are below 18. They have been the invisible face of the pandemic, to quote UNICEF. They will need 24 months, if not more, of investment to just come out of this crisis. How can we put, and to you as well, how can we put children back on the roadmap? They are not our priority at the moment. And you were speaking of resilience. One of the things that we say in public health, I head a Gandhian organization in India, we say it's mental health. When we speak of mental health and resilience, we say it's a connection between internal assets that a child has and external resources that a society provides. The pandemic really has shown us that that link has to be established. So to people who can make a difference for children from outside, UNICEF keeps advocating, but we have missed many opportunities to do that. And to you, Chief Minister Reddy, it's so wonderful to hear you speak about the healthcare system, but it will require persistence. Already this year, the central budget in India has a shrunken health budget. So how do we keep that going? Thank you.
Thank you.
The Minister starter.
It was a very lengthy question. I put forth a lot of them. But as she rightly said, we have constraint on the funds. But yes, this is something that we need to deal with it. And in spite of our difficulties, we're pushing through with it. And we've allocated a 3-year window where we're wanting to mobilize $2 billion, 16,000 crores into this whole setup. And we are heading in the right direction, and we will do it. And as far as the doctors are concerned, as you've just spoken, we do understand that this is a predicament that we need to deal with it. And that's exactly why we are trying to open up more medical colleges. We're coming up, the state had 11 teaching colleges, medical colleges, till our regime had come in. Now we are actually opening up 16 medical colleges. So covering taking every parliament as a unit, so that there is uniformity in distribution. And a teaching hospital and a medical college together would provide for postgraduate students to come in and provide for the healthcare. So.
Thank you.
Let me add a perspective, I think, on primary healthcare. I've spent a lot of time in India, and I'm quite impressed with the way that India is beginning to use digital in a way to enhance primary healthcare, especially when you come out into rural areas, like in many countries. The ability to connect to someone who's an intelligent person, but also over time, artificial intelligence actually opens up tremendous amount of low-cost healthcare opportunities, which I think we should do much more of. On your question to children, I think the real world there is prevention. The real thing that we can do in healthcare systems, and possibly companies, my company is involved in some countries with this, is to enhance good lifestyle development, be able to make kids live a healthy life, but also to be part of that. That's very little cost. It's amazing, I think, that we have this 97-3, and the 3 here is for early detection and prevention among children. If we double that, that would be an enormous effort with children and at very little cost compared to treating them when they have already become ill. So I think the real world there is prevention with children.
Well, if I can add a perspective there, I think that it is one of the reasons why children are not prioritized by the innovative cycle is the regulatory system, and in terms of clinical studies is daunting for a lot of different innovators to get into. And often the market size is relatively small. And when you think about access, you definitely need to think about how are kids actually being cared for, and the role of the caregiver and the role of the primary health system. As long as we keep talking about the fact that health systems are fragile, I think that you end up seeing that lots of innovators, wait for the problems to be solved before they innovate. The research and development pipeline, the the level of access for children is not going to change unless we all consciously make an effort to put children front and center in the response. And there are a lot of new platforms that are being developed. There's a platform called GAP-F, looking at priority products for children, how to design differently, what does access mean, looking at supply chain improvements. But it really must include the primary healthcare system, the preventative element of it, treatment, curative, and the role of the caregiver. I think that has to be in the system itself.
Okay. I'm going to open up the floor for more questions. I can see a hand here and a hand behind me. If we can just get mics to them so the questions can be asked. The lady over there had her hand up first.
Thank you so much, dear speakers. Should I stand?
Yes, you can. It's up to you.
Thank you so much, dear speakers. I'm Nupur Kohli. I'm a global shaper from the Amsterdam Hub. We are young people between the age of 18 and 30 from the World Economic Forum. I also work for the largest healthcare insurance company in the Netherlands. So my question to you is, looking at healthcare resilience, what do you think is the role of healthcare insurance in many countries where it's actually not available? And I feel it's a primary human right to also have healthcare insurance in many countries.
Is there a specific person that you'd like to answer the question, or is it open to the floor?
I would like Mr. Johansson and also their Chief Minister to answer those questions, how you view that. Thank you.
All right, can we
Okay,
take those two?
I think happy to. I think traveling around the world like we are, we have people on the ground in more than 100 countries, and we are selling drugs into 200 countries. It's very good to see the development in many countries, India, China, etc., where reasonable healthcare programs are being put in place, and mainly as a government effort. How to best combine those between private and government efforts, I think, is up to each individual country. Depends a little on how it's going. But it's beginning, to your point there on human rights, I think it's beginning to be recognized in many countries that this is indeed something that we need to do and often needs government support. From an industry point of view, what we can do and will be doing is of course to be able to scale medicines. I think to your point on children here, there are beginning to be regulatory opportunities, even though markets might be small, to be able to get a good IP protection, etc. All of those are important elements, I think, of doing what you're doing. But it's encouraging to see the number of countries and large countries that are beginning to go down the road of reasonable healthcare.
Okay.
As she rightly pointed out, this is a major concern. In fact, to address this, the country as such had, under the leadership of the Honorable Prime Minister, had launched a program by name Ayushman Bharat. It's more or less a combination of, it's more like an insurance part where the state governments are also involved in settling the claims. The funds come from central government, but it deals with 1,000 procedures or so. That is not sufficient, it's inadequate. So in the state of Andhra Pradesh, we have widened that scope, and we have come up with our own insurance scheme. It's called YSR Arogyashri scheme. I named it after my father because that's the kind of priority that I give to that scheme. So I just want it to be remembered, and I want to do a good job out of it. So what we have done is we've scaled the number of procedures to 2,446. From 1,000 what the central government supports, we had increased that to 2,446 procedures. And practically, we have distributed cards to 1.44 crore houses. And we've increased the limit for the eligibility of this card to income limit of 5 lakhs per annum. So anybody whose income is less than 5 lakhs per annum is eligible for this card. And 1.44 crores out of the total households of approximately 1.5 to 1.53 crores cards that households that we have, 1.44 crore cards are covered under this scheme.
Okay.
And the last 3 years, we've helped almost 25 lakh people get treatment free of cost here.
We have about 10 minutes. We're going to fly through a few more questions briefly from the audience. The Executive Director of UNAIDS is in the audience with us, Winnie Byanyima. I think she would like to ask a question. If we can get a mic to her at the back there with the black head wrap and the red top.
Thank you, Zinga. Thank you, moderator. And thank you, panel. Mine's not a question, it's a comment. And responding to the subject you're talking about, I don't think that we're going to be on track to resolve a health crisis that turned into an economic crisis without tackling the inequalities that drive them. We are not, health security strategies that neglect some people and protect a few privileged won't protect anyone ultimately. What do we need? We need debt cancellation, and we need to drive special drawing rights of the IMF towards developing countries so that they can have the resources to invest in health, in education, to end pandemics, COVID and other pandemics. We need, let me put it this way, debt repayments for the low-income countries in the middle of this crisis, where several times over they are spent on health, 9 times for Africa, 9 times more to debt repayments than to investing in health. This can't be a solution. So we do need to get rules of finance, rules of trade, and rules of tax, global rules, to work for developing countries if we are going to come out of a health crisis and an economic crisis. Thank you.
Thank you very much for your time. I saw there was a hand here, and then there was also a hand there. So if we can get mics to both of the participants so we can do rapid-fire questions. We have about 6 minutes left for questions from the audience.
Thank you very much. My name is Sheila Patel. I represent Shack Dwellers International, which works with urban slum dwellers in 33 countries. I want to give you a message from poor women in urban areas, but I have many friends in rural areas too. We know that real health delivery, sir, is at subnational level. And I want to know whether all of you see value in leapfrogging into involving your populations in promotive health. You know, it's taken us so long to acknowledge that preventive health is important. But in today's world, where along with pandemics and debt and disease, we're also dealing with climate change. And as many people as you said were affected by famines are being affected with poisonous fast food and are facing chronic diseases at a level with which people in India and China, we know with studies, there's a huge volume of people at very young ages getting chronic diseases like diabetes, blood pressure, and even children diabetes because they're eating white carbohydrates and fried food, which are poisonous.
Thank you.
So I'm saying it's much larger than just doing specific things. And economics of that have to come into the discussion about insurance, because curative insurance is not enough.
Catherine, would you like to respond to that, or was there anyone in the panel who would like to respond to that?
Well, the only point I would make about that is that I think I agree and with everyone here who talks about the importance of primary health care, and I think it's really important, but I do think that nutrition is another critical piece of this. And what we see in so many parts of the world is that children don't get proper nutrition and end up stunted. And once a child is stunted, they can never catch up, ever. So that investment early is so important on the nutrition side. And I think to your point, you just have to make sure that children have the nutrients they need so that they grow properly, their brains grow properly. And if not, I think we just deal with a lifetime of problems.
Okay. If we can have a mic on this part of the room, two questions here, and then maybe we're going to be able to take the last question there. All right.
Hi, I'm Tripler Pell. I am a primary care doctor and trustee of the John A. Hartford Foundation. And we've talked a lot about children, but I was just wondering if you could speak to the elderly population, which was severely affected during the pandemic and will be a future problem for both developing and developed countries.
Is there a specific person that you'd like to answer that question? Or it's open to the floor.
Yeah, just if someone could comment on the aging population in terms of prevention.
All right.
I'd be happy to have a shot at that. First of all, I think when the pandemic, the elderly were clearly the population in danger. And I think that was handled well in many countries, less well in other countries, where the vaccination rate did not go up high enough into the elderly population, and thereby also protecting them, but also protecting the rest of the world. Those are things that I think we need to work out with for the next time and see how we can do that better. Otherwise, the elderly population, are the people who really cost a lot in the healthcare systems. And if you look at how much of healthcare we need when we are older compared to when we are younger, then that's clearly something that needs to be looked at. Early detection, screening efforts, all of those things actually I think can catch disease very early. And let me finally make a point on this balance between curative and preventive. We are trying to spend 97% of all healthcare spending in curative mode and only 3% in prevention. Let me say that again. I think that's absolutely wrong. We seem to all agree on that, and every panel I go to, we agree on that, and then we go home and do nothing. So I think we really would want, as an outcome of this panel, to do something real there.
Okay. Second last question from behind us, penultimate question.
Hi, my name is Silvana Sinha. I'm the founder of Brava Health in Bangladesh, which is a technology pioneer here at the World Economic Forum. Our company offers integrated outpatient care. We're a private healthcare provider. So my question is about the role of the private sector and how we create more incentives for investment in the things that we're all saying that we need, including primary care and quality diagnostic testing. My company has raised $12 million to get to the point that we've served 360,000 patients, but we have no institutional funding because there are no institutional investors that are investing in my sector.
Okay.
I'd like to take that. So at the moment, the primary incentive that private sector responds to, and challenge me please, is really the availability of financing and de-risking some of the activities that they would be active in. And this goes for not only the pharmaceutical industry, but also private sector that runs clinics and things around the world. And I think we need to definitely change that to make sure that companies and private sector also recognize that there is a societal need and a social license to operate in these markets. And that combination is basically what needs to come in play in order for people to understand it as financial and non-financial incentives that need to be put in place.
All right, last question from the floor. Last brief question from the floor.
We'll make it brief. Thank you, everyone. Very interesting feedback. My name is Andre Guam, a physician practicing in the U.S., a physician in chief for oncology for a large statewide system in New Jersey. And in the last minute that we have, I just want to raise a question and maybe have your comments, is that how we build up, throughout the resilience, we need to build the trust and rediscover trust of the public into our healthcare system, particularly with discordant messages, even within healthcare providers sometimes, of what to do best, particularly in a pandemic. That was something very important. So, thank you.
Last shot at that question.
All right, go ahead.
Well, I think it's spot on. Building back trust means performing and making sure that as an industry or as a government, you're delivering on your commitments. So if you don't deliver on your commitments, then you lose trust. And that's basically the situation we're facing right now.
Thank you very much. Thank you to our audiences. Thank you to our audience for raising thought-provoking questions, and thank you to our panel for answering them so well and really taking a look at what we need to do in terms of policies, practices and partnerships to strengthen health system sustainability and resilience now and in the future, and sharing your experiences. I think what's come out is the importance of primary health care, collaboration with sectors, the importance of prevention and innovation, and getting ready for whatever may come. It's been a pleasure facilitating this conversation. Good morning. Thank you.